Uh,
Okay. All right. Okay, so hi everybody, Dr. Kogan. I'm saying this more for the recording for those who's gonna listen and recording. So we discussed that we're gonna talk about this topic of psychedelics. I hoped that I would find some information for you specifically on the psychedelics and the COVID, unfortunately, not happening. And I think I'm sharing the wrong screen, right? You seeing the consequence of slides, right? You're not seeing just one slide?
Yes.
Okay, let me redo this.
Yes.
I'm gonna share the right one. All right, that should be the right one. Okay. All right, so this is what we're going to talk about. It's a pretty complex topic. There's lots of things here. Many of you probably, well, actually, I don't know who's familiar with what. So maybe I can see some show of hands as to, is this term sound familiar to everybody or not really? LSD, ketamine, MDMA, DMT. I think ibogaine, I think there's R missing there, or maybe not. Ayahuasca, psilocybin, sanpedro, mescaline, a bunch of others. We're not going to talk about everything, obviously. There's never going to be enough time. The point of this conversation actually is not to sort of say, you got to take some of this stuff, but to really give you an idea of what's known and actually how theoretically, at least, the substances can be really profoundly beneficial for all chronic diseases, including long COVID, even though, as a full disclaimer, when I was doing the kind of lookup again, preparing for today, I didn't really find anything specific for COVID, but you'll see the relevance shortly. Okay. So there are sort of a couple of different classifications. So there's this classic psychedelics term, which doesn't really mean much of anything except how the studies occurred. So in 50s, 60s, 70s, there was a lot of interest, primarily in LSD and psilocybin and DMT. This is where things sort of started. LSD was actually created by accident. And then when it was discovered, the potency of it, it was actually used very heavily, particularly in Europe, for all kinds of psychiatric conditions. There's this man, Stanislav Grof, if anybody was interested, definitely read this. So he was achieving 90% cure of schizophrenia within a month using the LSD, very high doses, like doses to the point where people were completely unaware of anything, of any of the reality around them. So he treated over 1,000 patients. This whole stories are recorded with 900 complete recoveries, like basically cures, which is not known in psychiatry, right? He's still alive in his late 90s, and he wrote a bunch of books. When the LSD got prohibited, they actually developed, based on some of the work that he was doing, he developed a holographic breath. So if anybody's interested, look into that. That's basically many hours of intensive breath work that achieves some shift in consciousness. I did it once. I also did LSD a long time ago. It's okay to state that, that's fine. And I'll tell you, it's not the same. When you're taking LSD, you're really out there, and holographic breath is powerful, but it's not more powerful than any other deep meditative experiences I personally had. Classic also considered to be all serotonergic. So we know how most of the hallucinogenics work. So if you overflood serotonergic receptors very acutely, then there's a shift in perception that usually occurs. By the way, just for those of you interested in cannabis, cannabinoids, particularly CBD, but also THC, actually all of them, they also have some serotonergic impacts, just to a smaller degree. And serotonergic receptors are the serotonin receptors, basically. So the 5-HT2A is one of many. DMT, we're not going to talk much about it. It is an active ingredient in ayahuasca, but there's actually lots of different DMT containing plants. It's very potent. So LSD and DMT are both extremely potent substances. DMT we make ourselves in a tiny amount. So it's a kind of a more of an internal molecule, but not LSD. LSD is synthetic. Okay, so the key ones you want to know, and I'll tell you one at a time as to why. So the ketamine is definitely considered a psychedelic, even though at the very high doses of ketamine, it's anesthetic, actually still very heavily used for anesthesia in pediatric in children. It's legally available. It's a prescription drug. We at CIM have been doing intravenous ketamine for many years. It has its own benefits. It has its own negative sides. Its main benefit that it's legal and it's extremely cheap. Literally, the dose of ketamine for injection is something like 10 cents. The problem is that because it requires a pretty comprehensive process of infusion, if you're doing it IV and monitoring, so obviously it's not cheap because you have to, do it in a very controlled setting. It's also probably out of all of them the most side effect prone, and also has to be very carefully. The dose have to be selected precisely. For example, if you overdose psilocybin or pure MDMA, not much is going to happen to you. You have a more powerful trip, but maybe a little longer. But if you overdose ketamine, you can actually even suppress respiratory drive. So you have to be very careful there. It is interesting that is FDA approved now for the refractory depression in a nasal form. It's a very expensive drug. We're not going to talk about it. I'm actually highly against its use because it's not as effective as intravenous or intramuscular form because the way it's created. Ketamine is a racemic mixture. It's a mixture of different variants. And because it's a generic drug, what this company did to make profit, they basically formulated a portion of that mixture and patented it. And that's the pharmaceutical industry for you. And they made it about 10,000 times more expensive. Not like twice, not 3 times, 10,000 times. So the dose of nasal ketamine is about $800 versus what I just told you. The doses of IV ketamine is 10 cents. Yeah, take it for what it's worth. And so basically, whether you do nasal or injectable, by the way, the cost is the same or even cheaper to do injectable. The issue is, though, then now nasal is supposed to be covered by some insurances. But I'm not operating in that domain, so I actually don't know what they do. There are also compound ketamine, which could be for nasal form, which could be much cheaper, about $100 a month. Okay, so MDMA, and MDMA is not an ecstasy. This is a lot of confusion there, or Molly. Those are the street drugs. The pure MDMA that is made in the lab is a lot safer substance. So this is a really important separation. If you're getting an ecstasy or you're getting Molly, you 100% clear going to get some contaminants because of the way it's made. So we're not talking about ecstasy. We're not talking about Molly here because those are not the substances you want to take. You want to take pure MDMA if you ever want to take anything, because that's really where the safety seems to be pretty good. It's an empathogen. So in contrast to ketamine, which in a kind of a general terms, you would consider that anesthetic, empathogens are the group of drugs that when you take them, they make you more connected to the environment or to people around you. It is a very important. So each one of these psychedelics has its own niche of this kind of angle. So the empathogen is not going to be highly effective for depression or anxiety because once the drug wears out, the effect kind of dissipates. And because you're so positive, often the causality of depression or anxiety is not touched. But if you're in a severe trauma situation and you're lacking this connection, that's where the power of MDMA is. And there's a profound interest in this, particularly in the veteran population. I will give you towards the end organizations that specifically studying this substance, and some references, so you'll see. Now, ayahuasca is probably the most difficult thing to talk about, and I will disclose all my experiences. Why not? I did ketamine just to try it, didn't like it. I never did MDMA, actually, interestingly. I don't know, don't have an interest. Ayahuasca I did, and I did it in the correct settings decade before everybody started doing it in 2003, a long, long time ago, so almost 20 years ago. Not this time when I was in Peru, the first time when I was there. It's a traditional substance. It actually contains DMT as one of the plants, chacrua, that comes in the mix of two plants, contains DMT. The other one is blocking our body's capacity to break DMT in the stomach. So it's a pretty interesting process. It's very widely used. This one is what you can discuss as a purging psychedelic. So most people will vomit pretty heavily, especially if they didn't keep the appropriate diet. The diet has to be relatively light, low in like no alcohol, preferably no meat. So, if you maintain right diet, you don't vomit as much. There's not a lot of evidence for this one versus for ketamine MDMA. We have a lot of different clinical trials. For ayahuasca, there's not much. There's a lot of anecdotes. There is stories of cures, and I have seen people and talked to providers who are in Peru who claim all kinds of cures. But those are the anecdote stories. They're probably real. My sense of the substance when you're working with a shaman, that basically this is the healing on a completely different level that's not accessible to biomedical model. It is really more of an energetic, vibrational treatments that are profound, could be very profound when they're done right. This is also not for any reason a recreational substance. Nobody in their right mind will vomit for an hour for a recreational activity, at least that's my opinion. Maybe there's somebody using it, but I don't know. Okay, and then of course the rest of this talk will concentrate on psilocybin as being kind of the most, I think, most realistic, most potent for many things, most available, easiest to obtain at this point. Probably also the safest for a variety of reasons. And also this is, in addition to ketamine, it's the only substance, at least in 2 states, is now medically legalized, which is Oregon and Colorado. Now, DC is decriminalized it in 2020, and there is a clear path to legalizing medical psilocybin in district. I'm not exactly sure what the timing on this will be, but I can keep you updated. Actually, I was the face on a picture of the ballot for the decriminalization in 2020. If anybody cares, you can still find that. Questions, right?
I guess I am just disclosing for the first time, because I was always under the care of Dr. Kogan and now Ashley, but I've microdosed with psilocybin for my entire long COVID journey, not necessarily because of something that you prescribed to me. And I never really knew the space or when to tell you that because, of legality and different things. But I will say that I have a connection to someone in Los Angeles. She tests everything and she sends microdose capsules of albino white, I believe is the strain of mushroom. And I can honestly say that it has been the one saving grace through all of this, that I have been taking antidepressant. I take Effexor prior to long COVID and everything. And the only thing that really has helped me profoundly get through this experience has been the microdosing of psilocybin. So
you by far not the only one. I'll show you guys in a minute the studies on what people say. For full disclosure, we've also kind of working in this domain now, and we're seeing some amazing shifts, although we've only been doing it for about less than a year. But I think it's unethical at this point for a lot of physicians not to pay attention to this. This is how I feel because of the data I'm about to show you. So yeah, I think your experience is very consistent with what we hear. I think it's very consistent also with the fact that, it's expected to be inefficacious for the long COVID, despite the fact that we don't have the data. But this is the case where, as you'll see from other type of data, I think we can easily transfer the data to apply it to all kinds of long COVID symptoms.
I have a quick question, and forgive me because this is probably an immensely ignorant question, and I'm really ready for it to be. But I've never done any of these things and don't have any antagonism towards them, just never have. Is the conversation we're having, so I can listen well, is it a conversation that revolves around these things as mechanisms to help us during times that are difficult, whether physical or psychological? In other words, it's that which is amazing and needed. It's not a, I don't know what word to use in the medical jargon. It's not a healing process or curative process, which is fine if it isn't, because my therapy, well, it's all integrated.
Well, let's.
So how do I listen?
It's probably one of the most important questions that arises here, to be honest with you. Unfortunately, we simply don't know a lot, but what I'll tell you from what we're observing, the way I think of at least psilocybin as a highway, like think about you have some deep-seated trauma or deep-seated depression or something that has not budged in years of psychotherapy. And we see periodically a patient will take this stuff at higher dose and then microdose after. And then, they'll come from the experience and they'll say, well, I survived. I'm glad I didn't die. And by the way, this was better than 20 years of psychotherapy. Like we hear this repeatedly over and over again. And I'll show you data in a couple of minutes. Now, is this simply, are these medications or whatever you call them, are they simply allowing the brain to rapidly rewire itself or not rewire, but rapidly readjust? Because during the trip, your pattern of conditioning is gone. Your ego is dissolved. And then in there, something beneficial arises. Is that the cure process? If you talk about it from shamanic perspective or from perspective of energy, perspective from energetic healing, shamans would say your consciousness, your pattern of thinking is blocking your cure. And when that's dissolved, the vibration that shaman brings into the encounter moves you miles forward rapidly, instead of therapy is very gradual process. Now, could these substances cure other diseases? That is the even more interesting question. Currently, the only formal trial is ongoing is assessing psilocybin for Alzheimer's disease, and they're not looking for the cure. They're looking for a side effect, or they're looking for symptoms of Alzheimer's or around Alzheimer's. But eventually, we'll probably have some data. I have a feeling in the long run, these substances will enter the domain of disease modification for all kinds of things, including cancer, including Alzheimer's disease, etc. Before I see your hand, before that, Victoria had a question typed. So how do you find appropriate ketamine dose? It's pretty well understood. If we're doing it IV, it's a specific, like a per kilogram dose that gets titrated up. You start low and then you gradually increase. You have to see a practitioner. I would say for all of them, except if you decide to microdose, I would not do anything here without some careful guidance of experienced person, because you can end up in difficult places and in the bad places. Microdosing, we can talk separately, because it is the only thing that you can do without guidance, because really your operational capacity day to day doesn't shift at all. You just, Okay, so there was a question, right?
I was going to ask if there were any studies looking into combining sort of movement or energy work like Reiki or Yin Yoga with psilocybin and these things, because I personally found I did Yin Yoga training over this past summer and was microdosing through all of that, and I found that to be a very, it almost was like double powerful.
you would think that it would make perfect sense, right? Because anybody who did this, when I take this stuff, to me, it's inevitably just always a meditative experience. So, I don't, even if I take high dose of psilocybin, I don't get the visions. I just go into deep meditative state instantly, or, within half an hour. So there has to be some synergism, right? I mean, it's self-explanatory, but I don't think it's ever been studied. I have not seen anything, at least, but it would make perfect sense.
Thank you.
All right.
What do you think about the programs where you purchase a grow kit basically for psilocybin?
In my opinion, in my opinion, it's not worth it, because the system has to be pretty well tuned up, and it's very easy to get those things molded.
Yeah, it's so hard to grow mushrooms well.
I mean, you can, and it's some people who do it. The issue, though, like there are really reasonable sources all around, and you're probably gonna end up buying especially if you're just experimenting. It's just not worth it, because you're probably going to get a stuff that's pretty good quality cheaper, because getting the whole setup and do it right, not so simple. But I'm not necessarily telling you don't do it. I'm just saying don't expect it to be simple. It's not as simple as, like, how those mushroom starter kits and they just grow. This thing's a little bit more tricky. They have to be picked at the very right time, and there's a lot of minor tricks. You may end up collecting something that's not actually highly psychoactive, because there's a certain period of time, like it's more complicated than it looks, basically. That's what it is. Okay, I thought of putting this because it's very telling, right? So the typical medications that are prescribed up here on the right corner, well, except for heroin, obviously. This is some of these other substances we're talking about, the safest and the least addictive, and yet everything up here is a Schedule 1, so they tell us they're all dangerous, addictive, and they will kill you, while they, in case of LSD and psilocybin, way safer than caffeine. Compare the safety here, by the way. So this is, the lethality here is 0.001, for caffeine 0.01. So LSD and psilocybin is 10 times safer than caffeine. And you had your cup of coffee this morning, you didn't really think 10 times whether it's dangerous, right? And yet the government tells us that this substance is addictive and dangerous. I mean, so the MDMA has a little bit of potential of, because people, just like cannabis, if people use it recreationally, they can easily get addicted to psychological states, and not necessarily to the biochemistry of it. Quite different from narcotics, from heroin or morphine, obviously. So those would be the highest addictive potential. All right. This is just a side note. Okay, so let's talk about MDMA evidence. Small trials. There's a large one underway by MAPS. MAPS is probably one of the 2 largest organizations doing different trials. MAPS is standalone. The second large in America is Johns Hopkins Psychedelic and Consciousness Center. That's the academic one. The MAPS is standalone. They're independent, but they are nonprofit, and they're doing a great job. So this was, this is done. I don't think this is done by either group, but I just want to show you the results. So this is small. A lot of the studies are small. So it's only 12 people. So taking the active stuff and 8 placebos, so it's 20 patients. But look at the results here. So this is the veterans, right, mostly. And so 83% clinical response to the MDMA and 25% to placebo. So this is a massive improvement. If this would be a drug, by the way, it'll be the bestseller instantly for PTSD, because if you take let's say, antidepressants for PTSD for particular symptoms, I mean, their efficacy will be 5-10 points above the placebo. So it'll be, instead of 25, maybe 35%, and 35% response rate would be great for the drug. Now here's it's 83. So just to give you some sense. All right. Okay, so psilocybin. So psilocybin is the mushrooms, of course. There are a variety of them. So And actually, by the way they look, they often named. So like the albino that Anna brought up, so that cap is white or whitish. It's not purely white. But there's like so many different strains, and people keep arguing which one is stronger or whatever. So the active ingredient is actually this, this is the psilocybin, but the actual chemical name is 4-phosphorolact. I can't even say that, but you can read it. But there are actually others. So it's not the only main, but it's the main one. Psilocybin is the main one, but there are like at least half a dozen of other psychoactive substances present. When people do in a clinical trials, the typical dose goes from 25 to 50 milligrams of a psilocybin. And it's very linearly translates to the dry dose of the actual mushrooms. So 25 milligrams probably will translate to about 3 grams or something like 2 to 3 grams of dried mushrooms, and the higher dose, the higher. So the typical medium dose is 2 to 3 grams and high dose is 5 to 8. The typical microdosing can be, microdosing can be extremely variable. Very sensitive person can take 50 milligrams and have more response than a non-sensitive person to 500 milligrams. And I'm not kidding, I've seen this. I've seen a person taking 100 milligrams and having almost like a full experience. And then I had people taking 500 and barely feeling anything. That variability has all kinds of reasons for that to occur. For example, there's a belief that if somebody's taking antidepressant, you have to take a little more because the antidepressant kind of dulls the effect of the microdosing or the full dosing. But, there's a lot of lack of clarity just because this kind of what we call pharmacokinetic studies are actually lacking. So we don't exactly understand why there's such a great variability between different people. So evidence, this is where evidence is robust, meaning we have hundreds of different trials. They're all small, but they're for all kinds of conditions. So depression, anxiety, several different addictions, end of life, particularly in cancer, quality of life, and also just in end of life care. So like when somebody's dying, the dose of psilocybin, high dose, can have a profound induction of peace and comfort. And also some data on PTSD as well. And this is some of the current trials that are ongoing, which is really interesting, especially I'm personally mostly interested in this one. I haven't really seen some of my Alzheimer's patients take it to say yay or nay, but I'm trying to collaborate with John Hopkins PI, principal investigator, Alberto, who is doing the study. So we're trying to see what's going on there. How did you, so I will show you guys a reference to the John Hopkins website in a second, all the data for and this is probably the only reasonable alternative for you in terms of if you want to look into a study, because the MAP studies, I don't think they have any local sites, although I think there is a local site for MAPS for MDMA for PTSD. So if you're interested, there's probably is a way to do that. And again, I'll show you their links to them in a minute. So this is there are 2 clinical trials I want to show you with the effects. So this is, and look at this article, journals. This is not a left-right weird journal. This is JAMA Psychiatry. This is I believe #2 or maybe #1 journal in the world in psychiatry. So for this studies to end up in this leading journals is important. So this is 2021, so it's relatively a recent study. So what they did here, small study again, but now this is randomized. Now, of course, you're going to ask me, wait a second, how can they randomize this? Well, they can't double-blind randomize it, obviously, right? But they can single-blind randomize it, meaning that the researchers don't know what the participants took. That's good enough for this, because obviously placebo here is not happening for obvious reasons. So, but look at the data. So basically what they're saying, they did it, it was a bit longer study, so they followed them for 2 months, and they saw a large size effect at 5 weeks, and then it continued to be large at 8. And again, you almost never, when you look at the depression study, you never hear the statement large effect size on drugs. You bet if you hear a moderate effect, you're happy. Usually there's a minimal effect. So large effect is very rare. And so they had 17 participants, and at 1 week, 70% had response, which they defined as a 50% reduction in symptoms of depression, which is, which is huge. Again, if you look at the typical studies, in order for you to achieve this, you would need to titrate antidepressants to high dose, and you'll never get to 70%. Maybe you'll get to 50% at best. So again, and this is 2 doses. This is not taking something daily. They took 2 doses. So this is the sort of the power. And then this is the study from Hopkins. This again, look at the journal. Sorry, let me go back. This is the New England Journal of Medicine, right? So you're all familiar with that. This ended up in the New England because that is the John Hopkins, and the PI here was the PI there on the studies. What's his name? Actually, I don't remember who it was. Or maybe the prior study was from Hopkins. I'm sorry, I forgot which one was which one. But this is much larger. So this is 59 patients, and 30 were in a psilocybin, and then 29 were in a medication. So this is now, they've done their against placebo. So now they're saying, what is the standard of care for depression? Well, it's antidepressants. So let's compare antidepressants to the drug, to the psilocybin. So 60 patients, 30 were assigned to psilocybin, 2 doses. Notice that this is the lower dose. In a more, I would say nowadays, there's some idea that often patients will take 1 dose, let's say 20 milligrams, and then it'll go up to 30 or even 50. So they titrating dose up, but here they got both doses 3 weeks apart and being the same. Now, the second dose is pretty common because there is a thinking that the second dose tends to kind of not necessarily enhance the benefit of the first one, but it solidifies the benefit of the first dose. It's like makes it last longer. That's the, I think, current belief. Again, I'm not going to go through the doses, but what you're seeing here is here. So in 70% of patients in psilocybin group, there was a respondent, 48 in escitalopram. Now that wasn't necessarily statistically different, but at least it was clearly better. And then you look at the remission occurred in 57% of psilocybin and 28% of the drug. This is very common. So 20 to 30% remission rate from medication, or third roughly. That is an expected remission rate. You'll never expect 50% remission from the drug response. Here you had almost 2/3. So the basically psilocybin was twice better than medication. This was the study that really shook up everybody. After this study, I had a bunch of calls from our psychiatry department. Are we going to do this? I had some referrals, and there's just a lot of things started happening after the study because this was very well designed. This is controlled against standard of care. This is not controlled against placebo. This is very important difference. Because, the placebo, who knows, right? I mean, there's a lot of studies done against placebo. When you do this against gold standard, you can't ignore this. That's why this is in New England Journal of Medicine and not in some other weird journal. Okay. I wanted to show you this as well. So this is a bit older study. I believe that, yeah, this is 2016. This is what they started with. And this is Roland Griffith is the founder of the Hopkins Center. So this is what they first were able to do. They just looked at the life-threatening cancer. And what was really interesting, if you ever, and we'll definitely you can come back and look at the slides. What's interesting there is not just the results here, and there was a lot of patients here, it was 50 patients, but what they reported, there's some stories in there, and you can sense the profound shift that occurred people to get much more in peace with their diagnosis and just with the fact that they had a very limited time. And you can read this, but there was 80% of patients who showed clinically significant decrease in depressed mood and anxiety. Again, look at the numbers, like majority, right? So it's not minority, it's majority of patients that are getting it better. Okay, so the microdosing. So I knew this would come up, so I put, so there's not a lot of data, but this is a very big study. It's not controlled, but look at the number of people taking. There's 4,000 who took it and 4,600 who didn't. This was done via the app on a phone. And basically, people who microdose reported dramatically better outcomes of all kinds of things. So you can read the lower depression, lower anxiety, less stress. You know, they're basically rank their health better. They rank their mental health concerns better. So kind of all over, you know, and they're basically saying, look, microdosing has to be rigorously studied, which of course I wholeheartedly agree, especially because microdosing compared to the whole dosing doesn't require, in my opinion, a very careful individual attention at each capsule or at each dose. You probably should counsel people periodically, and the typical high quality microdosing will involve like a weekly or at least twice a month check in with a guide who's very familiar with the process. But even without it, it seems to work. Now, you should ask me what's lion's manes and some niacin and chocolate and B vitamins have to do with this. There is a thinking that when you take high doses of pretty much anything aggressively shifting serotonergic pathways, that you want to give some precursors. You want to kind of soothe the precursors. So the B vitamins, I actually give people B complex, not just niacin. I think they need to take all B vitamins, B6, B12, and folate. And in lion's mane also. So the idea is that it's sort of like, it makes the, especially with the high dose, when you take a lot, there's a morning after effect. You feel kind of mentally exhausted because so much you process. So this kind of helps to come out of that state better. All right, some resources. Sorry, this was wrong because I think I forgot to delete my own book there. I gave this talk to students. It was cannabis and psychedelics. So this is MAPS. So let me talk to you through first. I'll come back and then I'll click on this link so we can see them. And then this is Hopkins and Society of Cannabis Clinicians. Don't worry about that. Was for the other talk. Definitely, if you haven't read this book or listened to it, How to Change Your Mind, it's a great book. Michael is definitely one of like champions of the field, and he had his own experience. He changed his opinion. He talks about this very well. He interviewed a whole bunch of people. Great book, highly recommended. And then this is on Netflix, by the way. So they talk about history and some of this. I actually watched two of them. I watched LSD and Psilocybin. I love them. I'm gonna watch the rest. I haven't watched the rest yet. So that's, if you have Netflix, that's free. Okay, let me go back and show you this. So this is, oh, hold on a second. I have to bring the screen from the background. 1 second. It's coming. There it is. Okay, so this is MAPS, Multidisciplinary Association for Psychedelic Studies. So they particularly, so they don't study psilocybin, they study MDMA, they study cannabis, LSD, ibogaine, and ayahuasca. Now, mostly they study MDMA and they have a couple of studies on LSD, ibogaine. They have interest in this, but I don't think there's a lot going on here. On these substances. They're doing some stuff, but it's not, so there's only one study and it's in Canada. But if you look over here, so if you want to look into this, this is where you want to see. So they have a lot of different MDMA.
I don't think the screen is showing the website.
Oh, it's not? What are you guys seeing?
Does anybody else see it?
What, the MAPS website is there. It's like the top one.
You're seeing the maps? Oh no.
Yeah,
What
can
did
you see that, Victoria? It says like maps and then it says HTTPS. Maps.
I see the.
Let me reshare. I think the problem is with what ends up being shared. Hold on a second. Sorry about that. All right, how about this?
Yes.
Okay.
Yeah.
So this is the actual MAPS website. So I wanted to show you that for a couple of minutes. 1 second to get back to the other, there we go. So this is what's going on MDMA. There's a lot. So they have PTSD, eating disorder trial, anxiety. They're inviting people to start their own trials because they have some support. So if you want to participate in the study, you would click here. This is for therapists. and actually back in the day, we got a grant with them to sign up for training just when the time COVID hit. And then when they finally invited us, I kind of started doing other things. So unfortunately that didn't happen, but that's a very good organization. And some of this is phase 3. So phase 3 is kind of the last phase, the most advanced. So this is for PTSD. And that's a very large study. I mean, there are thousands of patients there. Okay, so that's MAPS. Now this is Hopkins. And I'm also going to show you how that's structured. So if you're interested in particularly studies, so they would everything is lined up here. So they have a smoking cessation. This is the one I was telling you about, Alzheimer's. They have the study looking at the weight loss, anorexia nervosa study. This is what's current: depression and alcohol use, post-Lyme, very interesting study. This is like a biokinetic study, obsessive compulsive breath work survey. So they're doing a variety of different things. So there's a lot of different things here that you can look into, and we'll make sure you get the slides. So with that, that's all I have. So I'm gonna stop the share, or actually I'll leave this on just in case you want to take notes or something.
Yeah, I know that Steve had a question about a meta-analysis. I don't know if he wants to talk about it.
Yeah, I just had a quick question about, so a lot of the studies are small sample sizes, and obviously
Correct.
with small sample sizes, you get a lot more power, which is normal and understandable.
No, you get less power. The
Well,
smaller the study, the less the power you get, right?
Well, you get less power in the traditional sense, but not in the sense when you're using a between means Cohen's D factor.
Right. You often have a larger effect size.
Right.
Especially when placebo is large, right?
Right. Well, I'm talking about Cohen's D. But either way, the point is, has anyone looked at sort of a meta-analysis of all of these studies to try to look at things like, for instance,
I think the problem is there's just not enough studies. So for meta-analysis to be decent, the studies have to be larger. And so my understanding is nobody tried it because there's just not enough. I'm guessing that somebody will do psilocybin for depression meta-analysis pretty soon, because there's probably by now close to enough. There are systematic analysis, but those are whatever.
Will we be able to get those slides from you?
Yeah. Well, I'll email them to Ashley. We'll send them to you as an attachment on top of the fact that you can always come back. I'll put this on my YouTube too, and then I'll share it with everybody.
Thank you.
Thank
you. If there's no question, what I'll do is I'll stop this so that we can kind of have our own time, right, without recording.